Okay, we have a few other sensors in the body that matter. Okay, the atria and the pulmonary arteries have baroreceptors that detect low pressure. Okay, that's different than the baroreceptors we've talked about so far, right, which really are high pressure detectors. In this region, they do not detect systemic blood pressure, and I give you a question there, could they? Right, so think about where they are. Where is systemic blood pressure, right? They couldn't, right, because it's on the other side of a valve. They could never measure it, so no, they couldn't. So they don't detect systemic blood pressure. They detect changes in blood volume, okay? And they dampen the increase that comes with adding plasma volume, which we're going to talk about later today. So essentially they are stretch receptors. Same idea, a baroreceptor and a stretch receptor really are the same, but how the body looks at them is a little different. So when these arteries, when the atria or the pulmonary arteries stretch, the information that goes to the brain is we have excess plasma volume, all right? So one of the things that we'll see from that is a trigger of a decrease in plasma volume. In other words, will increase urine output. So atrial stretch, these low pressure sensors in the atrial stretch, it means that when the atria get stretched out before contraction, which is a sign that there's too much venous return, right? We've got too much plasma volume, too much blood came back to the heart, right? Well, how do we get rid of the blood? The way the body does that is with natriuresis. Okay, so natrium, that's sodium, correct? So natriuresis is peeing out sodium. Now, one of the classic physiology terms you're going to hear probably your whole life is water follows salt. Okay? Well, the opposite is also true. Salt follows water. So if we increase our urine output of salt, we will increase our urine output of water. So water and salt leave the body, plasma volume comes down, stretch is reduced, and we have a positive feedback system, right? Or technically, negative feedback loop. All right, so atrial stretch detects too much plasma volume. Pulmonary artery stretch, same thing. There just is not a natriuretic peptide that results from that. Instead, what the body does in response to the pulmonary arteries being stretched is it triggers venoconstriction. It shovels that extra blood into the venous system. All right, and then finally, atrial stretch also triggers an increase in heart rate. So when the atria are really full before contraction, we have this reflex called the Bainbridge reflex. So when we have a lot of venous return, the heart speeds up. Makes perfect sense, because if we got a lot of venous return, we need to increase our cardiac output, right? Cardiac output is heart rate times stroke volume. So if we increase heart rate, we increase cardiac output, right? If we increase cardiac output, this extra blood that has made it back to the atria gets pushed out more effectively, all right? So that's the Bainbridge reflex. One of the places that we'll see this is when we give patients too much fluid, which is far more common than you might think. One of my long-term lessons for you is that IV fluids are medicines too, right? You can really screw up a patient with IV fluids. So, and one of the ways that we frequently do this is we'll give a liter of fluid, or we'll give 2 liters of fluid to a patient, and we'll so increase their plasma volume that they'll have this atrial stretch, and then we'll see their heart rate go up, right? So this is something that we actually see. I heard from Dr. Jones that you touched on the term iatrogenic, right? So one of the more common problems with fluid overload is iatrogenic, right? So, yes?
So you said they were low pressure detectors.
Uh-huh.
Wouldn't adding fluids or plasma volume
Make a high pressure, right?
Yeah.
These are very stretchy places, right? So the more fluid you put into the atrium, they stretch out as opposed to pressure going up. they're more compliant,
Yeah, okay.
right? So that's the difference. Very good question, but that's the difference. Okay, special cases, the CNS ischemic response. The vasomotor center is in the brain, okay? It's in the brainstem. When the vasomotor center itself becomes starved for nutrients and oxygen, okay, the neurons themselves become hypoxic, their response is to trigger a massive sympathetic outflow. Because essentially what the brain is seeing is that it's being starved for nutrients and oxygen. The brain is very selfish, okay? The brain will kill the body to keep itself alive. And this is an example of that, right? That when it doesn't have enough, it's going to make powerful sympathetic outflow. That's going to increase blood pressure, increase cardiac output. Now, in a normal case, that's going to restore cerebral blood flow. Now, the downside is, it depends on what the problem is, right? If the problem is that you've got a brain bleed, for example, this dramatic increase in blood pressure and cardiac output is going to make that worse. So sometimes this reflex is not a good thing, but it nonetheless happens anyway. So this CNS ischemic response, this is not playing a role in normal blood pressure management. Okay, this is only playing a role when we have something directly affecting blood flow to the brain. So either increased intracranial pressure, lack of massive loss of blood, so massive hemorrhage, those kinds of things. So the Cushing reaction is a special case of the CNS ischemic response. And the Cushing reaction is directly related to cerebrospinal fluid pressure. Okay, remember the brain lives in this, sort of floats in this fluid, but the brain's also surrounded by a bony container, right? Very non-compliant container. So if we have increased CSF, we have increased pressure. All right, so what happens when the CSF pressure is high enough that it exceeds arterial pressure? Now we have a blood flow problem, right? Because the pressure in the head is greater than the pressure the heart can make. So there's no pressure gradient between heart and brain. No blood flow, right? So the response to that by the vasomotor center is to keep increasing blood pressure and cardiac output in an attempt to get blood flow to the brain. So you can imagine that this can be kind of a death spiral, right? Because you're making more cardiac output and more blood pressure. If the cause of your CSF problem is blood pressure and cardiac output, well, there's your problem, right? You've got a death spiral. So one of the ways that we break this cycle is we put a hole in the head, right? We call it a bolt. We put a bolt in the head and let the pressure out so that blood can get into the brain. So more on that in medicine, but it's an interesting one. Okay, some other effects. We have a lot of venous blood that lives in our abdomen all the time. We have you're not in the abdomen yet over there. Okay, you will be. There's a lot of vasculature in the abdomen. Okay, so the abdominal compression reflex is a way to, we talked about venoconstriction, how the veins get smaller and push blood into the circulation. Well, we have a lot of venous blood in the abdomen. So when the sympathetic nervous system has a decrease in blood pressure, one of the things we'll see is abdominal muscle tone will increase. In other words, the abdominal muscles will contract around the abdomen, and that effectively reduces the amount of blood in the abdomen and pushes the blood up into the heart so that it can increase in the circulation, right? So that it compresses the large vessels. This is one of our methodologies for dealing with a low plasma volume, right? So let's say you've had a massive hemorrhage. One of the things you'll find in a massive hemorrhage is the abdominal muscles will start to tighten up. And it's because of this. The body's trying to reduce the volume in the abdomen to increase the circulating amount. And then skeletal muscle contraction. We talked about the skeletal muscle pump and how it works, so we're not going to get into that again. But one thing that's interesting is exercise, or even anticipating exercise. In other words, you don't actually have to exercise, you just have to be planning to, right? This is the magic of the brain, right? Will cause compression of the arteries and veins that travel through the muscle. So essentially, before you start to exercise, the skeletal muscle pump is already active, right? It's already squeezing a little and pushing blood back to your heart. So we get an increase in venous return even before we start to exercise. Now we get a massive increase in venous return once we start moving around, but some interesting effects. Okay, then the last sort of effect of the nervous system and the system that we see are the respiratory waves. When we look at a tracing of arterial pressure in an actual patient, okay, so they put a line in usually the radial artery. They hook up that line to a pressure transducer, and then you get a number, right? That'll tell you what the pressure in that artery is. Well, if you look at that on the monitor next to the respiratory curves and rates, you'll see that there's a relationship between the two. Your blood pressure changes as you breathe. Not a lot, but enough. Enough where we get kind of a waveform about it. So the reason for this is because of how the lungs work. When we breathe in, we lower the atmospheric pressure, or we lower the pressure in our chest, okay, in order to bring air in. Well, that same process of lowering the pressure in the chest, like we've talked about before, it has a tendency to pull blood up into the chest, right? So we have this relationship between venous return and breathing. So that's one piece, is the suction tends to pull more blood up. Then that next beat is bigger with more pressure. So we have an increased pressure, blood pressure with inspiration. The other part of this, which is a little harder to describe, is that the vasomotor center lives very, very close to the breathing center, okay, the apneustic center and the pneumotaxic center. So when the vasomotor center is activated, or I'm sorry, when the diaphragm, or when the area of the brainstem that activates the diaphragm is activated, that tends to spill over into the vasomotor center. So every time the diaphragm contracts, there's a little bit of a signal from the vasomotor center to increase sympathetic outflow. In other words, increase vasoconstriction, right? If we increase vasoconstriction, blood pressure goes up. So here's another example. When we breathe in, there tends to be an increase in blood pressure. So short version, as we breathe, blood pressure rises and falls. It can be as much as 20 millimeters of mercury per cycle. How is this clinically relevant? It isn't. It's interesting, right? And you can see it on the art line. So when you're watching an arterial line in an ICU or ER, don't freak out if it seems to vary a little. It's supposed to. That means your patient is breathing.